I would take the process.
Jim Nolan and Sean. Maybe based on the numbers that they're good for, I know Jimmy and Jim should be good, they don't have to be. Michelle's kind of a toss-up.
There are 3 participants on the call, including you. You are joining your conference as a participant. For a menu of available commands, press star pound. We are here.
I'll call this meeting to order.
I'm here too.
Does that help?
Is that Hal?
Yep.
Okay, and we have Jamie.
Yes, I'm here, and Mike Hensley as well.
Okay, this is Marcia Cox. I'm calling the meeting to order at 4:01. Jamie, could you call the roll, please?
Absolutely. Dr. Atasi? Amy Barney?
Here.
Al Christensen?
Here.
Marcia Cox?
Here.
Pat Rooney?
Here.
He said here.
Julie Septine?
Here.
And I'm just confirming Dr. Atasi is not there. Is that correct?
He's not here yet. He is on his way.
Okay. Okay, thank you.
Okay.
You have a quorum, Madam Chair.
Thank you. We'll stand for the Pledge of Allegiance and a moment of silence. I
pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation under God, indivisible, with liberty and justice for all.
Agenda item number 2 is call to the public. I don't know if we had any forms filled out for a call to the public, but I would like for Mr. Hensley to read the description if we do. Do you have that information available, Mr. Hensley?
No, I don't have that form in front of me right here, Madam Chairman.
Okay, I've got one here. I'll just read it briefly. Just for the public's information, you are invited to provide a call to the public or address a call to the public. We typically will ask you to fill out a form and present that to us. Call to the public is limited to 5 minutes. At that time, you would present that to us, and calls would be from members of the public on items that are not on the agenda because of the restriction imposed by ARS 38-431.01, discussions and actions on items brought before the board during this time will be limited to directing staff to study the matter or rescheduling the matter for future consideration and decision at a later date. Do we have any requests for call to the public? I don't have anyone standing up at this time.
Marcia, is one of the things that you're discussing, is it closing the clinic? Is that on this schedule?
We have one agenda item, and that was published it was posted on the website, and it's agenda item 4, review and update regarding status of negotiations with Cerner for management and operation of the health and wellness clinic.
I just wanted, I filled out a form, but it's back here on the desk. On the matter that you're talking about, are you when you're talking with Cerner and all of this other stuff, are you still considering the fact that we need to have the clinic open, or is that something that's going to be talked about later in the...
I think that's going to be discussed in the information that we're going to have under old business, so that would be under the agenda item 4.
So then you can't speak about it until...
That wouldn't be under call to the public.
Okay, thank you.
Anything else under call to the public?
Madam Chairman, this is Mike Hensley, and just a reminder of the language that you did read, which is consistent with the statutes, is that any item that comes up on the call to the public, of course, is not a dialogue between the board members and that member who's asking the question at the time. The only thing we can do is, one, either direct staff to look into it or put it on a future agenda, so it will be agendized for discussion.
Thank you. So we have an item 2 and then a 4, and I think the reason for that was because there was a question as to whether or not, because item number 4 is old business, if we were going to need to have an executive session. And I believe based on some conversations that there was going to be a need for that.
Yep,
Can you comment on that?
yeah, Madam Chair, Jamie, this is Aaron speaking. The item was agendized for an executive session because it's contract negotiations, so it's to do the report and seek advice from council on the status of the contract negotiations with Cerner. And then the intent is to move out into open session and take whatever action the trustees determine to take.
Okay. Before we do that, can I comment, Jamie, that Dr. Atassi is now present?
Thank you, Marcia, I appreciate it.
404, Marcia?
At 4:04?
Yeah.
Got it.
And can we have a motion to adjourn to executive session?
Motion.
Second. And call for the vote?
Dr. Atassi?
Yes.
Amy Barney?
Yes.
Al Christensen?
Yes.
Marcia Cox?
Yes?
And Julie Sassine?
Yes.
So we will adjourn to executive session at 4:07.
And Madam Chair, before you do that, Jamie, can you make sure that Hal has the other call-in number, the second conference line number when we hang up?
Yes.
And because of the size of the audience, we're, with permission from Superintendent Asire, we're going to use her small boardroom. So we'll adjourn to executive session.
Do I get to?
Call the regular session back into order at 4:36. Do we have everybody back on?
I think there were 2, so I told
Yes, Mike and Jamie are here.
Mike and Jamie. Hal, are you here? I don't think he's in yet. Jamie, Julie Sassine had to leave.
Gotcha. I will make a note. Thank you.
Thank you.
.45 p.m. I got it.
Thank you. So we're just waiting for Hal.
Yeah, I think it takes them a second to dial in.
Steal those glasses.
Is that you, Hal?
I'm back, thanks.
Okay. So we have Hal back on the line, and we have Mr. Hensley and Jamie, our secretary, and we're back in regular session, and we have a presentation that Mr. Collins is going to do for us on the update. Do you want to do that now?
Your call, Madam Chair.
Okay. I think we should, because that's going to pertain to the review and update regarding status of negotiation with Cerner.
And then, Madam Chair, just clarification, this is actually under that item, so this is the lead-in for that item?
Yes.
Okay.
This is agenda item number 4.
Okay.
So this is old business.
Okay, so Madam Chair and trustees, just to run everybody through the background on this, let me get my... So the background on this, I'm going to kind of direct a little bit over towards everybody here so they've had the background. The Cerner Clinic is one of 6 vendor contracts that are currently in force on the EBT that were found to be void due to essentially open meeting law issues, which was that they were not adopted in a public meeting. So we've been directed to renegotiate all 6 of those. Cerner is the largest of those 6, so Cerner was the initial focus. We still have these other 5 to actually renegotiate to, and these are the other service providers that provide services to the trust. So with Cerner, we've been engaged in negotiations with, under the terms of a 60-day extension kind of basically that they would operate under literally just under a 60-day contract. We were directed to go back with them, with counsel for the trust, to renegotiate the overall terms of the agreement. We attempted to renegotiate pricing with them and other terms of the contract, and then the results of that would have to come back for the trustees. It's important to understand that that 60-day document said basically two things. You have 60 days until the last day of August to negotiate a contract. If we are unable to reach agreement, then the contract sets the clinic into a mode to wind down by December 31st. So it's an all or nothing deal. So if the clinic closes, then there's a phase out of operations through December 31st, where Cerner would have to continue operations under the current terms, under the current staffing through that period of time. And then it would be incumbent on our firm and the trustees to redesign the benefit plan. I'll get into that a little more for effective date of January 1 of 19 to finish out the current fiscal year and then to go beyond. With that in mind, we've engaged in a parallel process of pricing alternative benefit structures with a trust actuary to do that 6-month period and then for the period beyond that. So that's kind of the bigger picture background. So at August 20th meeting, Cerner presented a final offer. That was discussed in both open and an executive session. The trustees requested that we go back to Cerner and ask them to extend it for another 30 days to let us refine some of their offers, get some difference on the pricing, and they declined. So they basically said that's our last and our final offer. So they're done. So the decision that is going to be faced today is whether or not to keep the clinic or to close it. Okay, so the background, for all purposes, the budget background is the current year budget for the trust. The Lake Havasu Schools Employee Benefit Trust includes a deficit that was built in of $472,000. So we went into the year expecting to lose $472,000 just basically due to the funding. For the budget for the trust, for the clinic, strictly for operational issues, this includes nothing for claims, is $663,000 in management fees and then another $86,000 for things like rent and utilities and telephones and internet service and landscaping and insurance and whatnot on the buildings. So that's $86,000. The budget impact of that final offer was about $150,000. These are all rounded numbers. $150,000 reduction in the operating costs. It would reduce the staffing from 2 nurse practitioners and 2.5 MAs, medical assistants, down to 1 nurse practitioner and 2 MAs. It would cut the hours of the clinic to 40 hours a week. The initial offer was that it would end all Saturday hours, but they have since modified the offer to say that they would consider doing 1 Saturday a month and then staggering hours during the week to kind of get high and low hours in there early and late. There's no assumption of any impact on the operational budget, the $86,000. The rent doesn't change, the utilities don't change, that type of thing. So basically their final offer was a reduction in staff, 50% on the professional side, a little bit less on the support staff, and about $150,000 annual impact. So what that brings us to then is if the clinic stays open with that revised offer, the $472,000 projected deficit goes on an annualized basis, reduces by $150,000, so it becomes $322,000. If you do a half year, then it reduces to $397,000. So that would be the projected loss for the year. If you close the clinic on December 31st, 2018, the deficit on an annualized basis becomes a surplus of $190,000, and it's $100 for a full year and $140,000 for a half year. So those numbers are important. So the current lease on the building expires in March of 2020. Cerner's offer runs through that same date, so they would be aligned. The key distinction I think in here on the service level is that we're attempting to do this on price because we've got a $472,000 deficit today, and then the other figures in there. And Cerner's been very clear, I think, and correctly stated that it is not their corporate philosophy to compete with a corporate model. I'm sorry, with a community model. That they do a much larger, longer meeting. They do 45-minute meetings with people. That they're a primary care philosophy, and they're geared around that. Whereas on the community side, you might do 2 or 3 visits in that same period of time if you're in a doctor's office. So they're basically saying we're never going to compete with that. It's not where our model is, and we get it. That's valid. So the other discussion points, the benefit structure today, and this leads into why it would change if the clinic closed, is the entire plan here that's offered through the trust and through the district is structured around that clinic. And the way that operates in real time is that the cost at the clinic for participants are very low. There was no cost for anything as of July 1. There's a couple of different co-pays, and then we shifted out drugs out of the clinic and labs out of the clinic to save money. But the reality is that the co-pays to participants are very low, and the cost to the clinic, to the trust, is actually very high. It's about almost twice what the costs are in the community for services. There's also, though, higher cost to participants outside of the clinic. So every employee, spouse, child that goes, in an effort to drive people to the clinic, the co-pays are very high. They're at I think it's $55 in for an office visit versus $10 now at the clinic. And then the deductibles and co-insurance are also set quite high in our experience. With, can I get my actual numbers in here? So we got a $2,500 per person deductible, $5,000 for the family, and an out-of-pocket max of $6,500 and $13,000. So essentially what we have happening is the trust is paying a much higher cost per visit, recognizing the disconnect on the philosophies there, but employees outside of the clinic are bearing higher than we are used to seeing costs in the form of higher out-of-pocket maxes, higher deductibles, higher co-pays. So in essence, what we have operating is an informal subsidy from two sources to keep the clinic, in an effort, I should say, to get the clinic to be economically viable. So if the benefit structure without the clinic, how does that look? And what the challenge will be if the decision is made not to accept the final offer to allow the contract to lapse. The challenge will be to redesign and lower the out-of-pocket cost for members using the freed up dollars. We have to get rid of that deficit first, and then we have about $190,000 left over. So in plain English, what that means is how do you use those dollars to lower the co-pays, lower the deductibles, lower the out-of-pocket maxes, so that employees are bearing less of the expense. We have to do that use those spare dollars without getting back into a deficit, and then we would expect actually to offer employees more than one benefit plan, and that's what we've been pricing out. And we also do that while we're mindful of the fact that the district is simultaneously spending or winding down its subsidy of the dependent side. So we have to find that balance where by the time the district's done with its dependent subsidy, that the coverage is affordable. And I wish there was secret sauce in there or something, but there's not. That's going to be a tough one to do. So next steps really for the trustees is to make a decision whether or not to keep the clinic, which means do you accept the final offer or not. And if not, then we accept Cerner's offer, which is, well, we basically live to the agreement, the 60-day agreement, which is the clinic would close down on December 31st, and they would provide the same level of services in the meantime. If you keep the clinic, there's a fiduciary question there, which is you come into it recognizing that we have a built-in budget deficit that will have to be addressed at some point. For the background for those in the room, and many of you know this, apparently the clinic got into, or not the clinic, the trust got into some severe financial issues back in 2016. Since that time, the district has pumped $2.7 million in addition to the premiums into the trust. So the reason that the trust has some buying time right now is that 2.7 additional funding. Because the trend line was actually down, I believe it was, if I remember correctly, it was under $500,000 in assets when everybody walked out and they tried to put the rates up and everything. So that 2.7 million refloated the boat. So what we're doing is we're trying to buy time here to get it back to a stable financial position. So if the decision is made to keep the clinic, then it has to be done recognizing we've got a structural deficit built in. One way or another that has to happen. So you either got to find more money or you have to reduce benefits to cut the dollars flowing out of the trust. There's really not too many other ways around it. And then we would negotiate the final terms with clinic, with Cerner, with the understanding we're trying to get the best terms we can, but we're essentially there on pricing. If the clinic closes on December 31st, then employee education and communication hits front and center. We have to go out and explain what's happening, the rationale, the money, and whatnot, in whatever format the district decides. We have to get back with Cerner through the attorneys to make sure that they will honor their portions of it, to continue to staff it according to the current agreement through December 31st. As I mentioned earlier, we have a simultaneous track here going where we've been pricing out options. We have a meeting scheduled for September 6th where we'll go through every one of those options. There's about 15 or 18 plan design options in there. We then have to get with Gilsbar to get them reprogramming all of their computers to address those changes and handle it on January 1st. We'll have to renegotiate the stop loss contract. This is the insurance policy that protects the trust from large losses. And then under federal law, because this would be a significant change to benefits, we have to offer a mid-year open enrollment. Our expectation on the mid-year open enrollment is frankly not a ton of changes. We would actually be improving the benefits. Our assumption is that we'd actually have more people enroll on to it. We don't know. We have to also do all of this while we're communicating with the district to make sure we're not blowing their budgets out of the water for the remainder of the current fiscal year. And we're also doing our pricing with very early indications of what the 1920 year would look like. And I say very early, and I put about 35 asterisks on there because we expect them to be very conservative. That's a long way out to project. But given this type of change, we would have to do that just for the district. And Madam Chair and Trustees, I'm happy to answer any questions that you may have.
So
Here, I had a question.
Okay.
Okay, so right now we're operating at a deficit of $472,000 annually, correct?
Yeah, that's projected, Hal. That's correct.
Okay, so, but, all right, so, and I know, Jamie, I think previous conversations talking about a provider other than Cerner for the clinic, that there's no way it could happen in a short term, like before the end of, the end of December, which is what we're looking at. The question I had is if we can continue to a Cerner through March 2020, which essentially is about a year and a half, I think it's 19 months. If we continue to a Cerner under their new proposal, which will save some money, but we're still operating in a deficit, I'm understanding that. But I heard earlier, I think, that there's a pretty good participation in the clinic by the employees, spouses, and dependents. So I guess my question would be, would it make sense at all to, with our eyes wide open, go into this with Cerner through March of 2020, and in that 18-month time frame, look for another provider that you may be familiar with, Aaron or Jamie, that could operate this clinic in a more traditional manner, like some of the other ones you've mentioned, other than the way this one's, we're just digging a deeper hole. So that would be my initial question.
Is that for me, Madam Chair?
That's for you or Jamie, Aaron.
Okay. Jamie, do you want me to do that one?
That would be fantastic.
Okay. Madam Chair and trustees, at the risk of tap dancing a little bit, I know there are clinic providers out there. I don't know that we could get it done in 18 months. We could probably do an RFP, put one together, and do it. I don't know. I would think this would be frankly more like a 2-year process or something, like, just FYI. And the reason I say that is I think, having reviewed all the documents that are available, what I see with this one, the way this was done, there's no reflection on Cerner, just to be full disclosure. But I think the way that this was done, and I would want to do it differently, Hal, is
okay.
that I didn't see any evidence in here that that there was any goals set, that the structure that was selected was actually directed at any of the specific areas where the claims are coming from. There were no metrics put in place on the trust's side that said these are our targets. If you get to them, you are not compensated. There's some penalty, and consequently, Cerner's internal billing systems or even visiting system was not used in a way that we could ever measure anything off of, and that was because they were never asked to. Again, it's not a reflection on them. So. And the reason that's exactly why I'm saying I would be concerned about time on that, because I think given the size of this district and the number of employees that are on there, if the goal is to get a clinic to measurably have some impact on the claims, which I think ultimately is it, we're all trying to keep healthcare affordable for everybody. I think it would be very tough to do that in the best of circumstances given the size of this population, and without having those clear metrics and the mechanisms that you're going to use to measure whether or not it's doing it. I think it would be a fool's errand, and I would not recommend it. So long story short, you can do it, but I think it would be very difficult to do it competently in that period of time.
Aaron, do you manage any trusts that have a successful clinic?
This was actually, the question for the record was, do we manage any trusts that have a successful clinic? No, this was the first one that we had encountered. Mike Shunning, the actuary, works on at least one, I'm not sure. He has a very large multi-employer one that he works on in Las Vegas, and that's where the issue came out, where the conversation came in on creating the metrics, setting the system up to produce the reports, according to what's spec'd by the client, and then actually measuring any impact on claims through an actuarial process and through an objective process where it's done integrating the claims with the actual member utilization.
There's also something that I guess I want to make sure that is out there for conversation and discussion. We've been trying to work with this clinic, and I know that I've been personally trying to get information either on this board or as a private citizen for close to 3 years, more than 2 years at least. But part of the information was confidential, private, secure, whatever the number, whatever the information happened to be. The clinic, and by all rights, it's a for-profit organization. We understand that, we know that. The way that it was presented to this district was done, and we know because this is a voided contract, and that's why we're here today. There was a lot of information that we were never able to receive, but as part of this body and part of this board, we've asked numerous times and countless times for information that still we have never received information, and that's very disappointing. But what I want to also remind everybody in this room is that when we reminded Cerner of where we were with this, and we asked them to help us to understand their fees, and we were able to determine what those numbers were, and to help us to get to a happy medium, if you will. Their answer, their solution was not to reduce their fees, it was to reduce their staff by half.
Guys, I hit a dead zone, I just came back on, sorry about that.
Okay, all right, sorry. So the answer, the solution that Cerner gave us was not to reduce their fee, it was to reduce their staff, their nurse practitioner staff, by 50%, by half, and to reduce their hours by 20% or 25%, from 50 hours a week to 40 hours a week. And that was going to be for the remainder of their term, so that takes us out to June of 2020. So we're talking about another, is that almost 2 years? And so what we're talking about is beginning. Basically what that means to the people that use the clinic as their primary care provider is that you will have one nurse practitioner instead of two, and you will have 40 hours a week and 1 Saturday a month and reduced hours during the week. So everything will be reduced, and I mean, and our fees are going down 5% because they're cutting their staff in half, and we will be obligated to stick to that for almost 2 years, and we still have no guarantee that they are going to give us any information on whether or not their model is making the people that are using them as their primary care providers healthy, which is what they had promised to do in the beginning. That was the whole idea behind the program, was that we were going to see a potential $1.6 million in savings because people were going to be healthier. That was the whole presentation. It has been for 5 years. So for us to be able to say we should agree to them coming back to us and saying, and all we wanted was another 30 days to think about this. And they said, no, this is our number, and that's the way it is. And not only is this our number, but our number means that we're going to cut our staff in half to take care of however many people go to this clinic. And I'm still not even sure how many people, are primary care providers. And I'm not trying to, I guess I am trying to impress upon the people in this audience that the goal of this trust is to make sure that we provide the best possible plan that is available to you, the dollars that are there, the benefits that are there, and not just one nurse practitioner and 2 medical assistants, because that's what it would be for however many people use that clinic, and 1 Saturday. I mean, so it's dramatically compromising or reducing the availability of your service because we really like that clinic. I mean, if there are alternatives out there that could make your life easier using virtual medicine, I mean, if you have an opportunity to have other programs, why would that be so bad? And then if you have that for a period of time, there's nothing that says that we can't go back and look at something different at a different time. All we're trying to do is get this plan stabilized. And even if we do accept this plan, please understand that we are still at a deficit. We will not come out of this deficit until we make a substantial change, and we are not we're not using the Cerner clinic as the anchor to your benefits. And if we continue to use the Cerner clinic as the anchor to your benefits, there is a very good chance that your premiums, not just the district's premiums, the money that the district puts in, and they take money out of all of the extra little pots that they have to come out of all of the proposition monies, but your premiums, the dependent premiums that come out of your paychecks, all of that money, all of those premiums are going to come up. And I, for one, do not want to experience another 2016 and same people on the sidewalk. You've had a chance to look at this since October, and you came in, Mr. Collins, as our consultant, and had a chance to look at hundreds and hundreds of pages. I'd like your opinion on what you've seen.
Well, Madam Chair, for me, for our firm, we have, like I said, we've gone through quite a bit of data on this. And going back to my earlier comments, I think, if I would summarize, I don't believe that with the current contract, with the current structure, I don't believe that this particular model, as set up, will return the money and break even. And I again, for the record, I don't point the finger at any way at Cerner on that. I think the issue is that I'm picking my words carefully here, but I believe the process that led to the selection was missing significant elements related to pricing, relating to accountability, relating to how visits would be calculated. I think it was missing any substantive metric at all. So I don't believe that I don't believe it's sustainable.
in its current configuration, and I believe it, as popular as it may be, because I would love to have that kind of free access myself. As popular as it may be, I think actually the trust in the district would be better off redistributing the money to all employees through lower deductibles, lower copays, lower out-of-pocket maxes. Because when you look and you're looking at, if you have a family, you have an exposure here of $13,000 a year on that out-of-pocket max, the $2,500 to $5,000 deductible, and then the out-of-pocket max on the 80/20. That's a much bigger exposure than there is for a primary care visit copay. So I think the greatest good in terms of using the assets that are there would be, one, get rid of that deficit, and then two, look at that benefit structure and lower some of those out-of-pocket max. And because I don't believe this model in Lake Havasu schools will ever, in the current way, I don't think it can be reformed sufficiently to get it back to even.
Can we say anything yet?
Did you have a question?
There has to be a question.
Sure, absolutely. Could you stand up? Can you state your name, please?
Patty Baser.
Patty Baser, thank you.
I understand the cost and stuff, and I understand what you're saying, okay? But our selection of doctors in this town is not widespread. It's hard to get good doctors, and then if you get a doctor, they're not getting appointments for like 2 or 3 months to get out there. Most doctors take off early Friday afternoon, and I don't know of any doctor that's open on Saturday, so that means those of us that use the clinic then would have to go to the emergency room for an urgent care. I can't see where that cost is going to be beneficial. Why can't we do what Hal suggested and find, if you're not happy with Cerner, yeah, it may not be feasible, but why wouldn't we try to go out and get somebody else that can manage that clinic? That clinic means a lot to us that use it. Those people, we only have one pediatrician in town. If a child gets sick, they can get to the clinic most of the time the same day or within hours, depending on what it is. Otherwise, all those families with children, but we only have one pediatrician, are now going to have to go to the emergency room. What's that going to do to our cost? At some point in time, I think that we as employees should have a voice in this decision.
So I appreciate, and I appreciate your comments. What I would like to suggest, and I have been doing some research. I actually went on a website and I found 377 doctors in Lake Havasu City that are accepting new patients. And I also found of those 377 doctors.
Excuse me.
She's got the floor.
Of that, 39 of them are family nurse practitioners accepting new patients. 10 of them are internal medicine that are accepting new patients. 20 of them are family medicine that are accepting new patients. 15 of them are PCPs that are accepting new patients. So the only one of those that are that wouldn't take peds are internal medicine. Now, the point of me showing you this is that there is information out there that is available to show you and to find physicians that will accept new patients. If I were looking for a new doctor and I needed to be able to see a new physician, for example, in January, I'd probably be looking now and getting established. That would be just a suggestion. But one of the other things, remember that if you did have a chance to look at the presentation that we did, the video that we did, if you went on the video and looked at it and looked at the presentation, one of the things that we were talking about was doing virtual telemedicine visits. And in the state of Arizona, you can be sitting in your house, laying in bed, and do a visit with a physician that you've never met before because it's an urgent care, 24 hours a day, 7 days a week, and be seen and be prescribed the medication. So if it is an urgent situation, you don't necessarily have to see someone in an emergency room. And urgent care or telemedicine has been around for over 20 years, and it's been very, very successful in the state of Arizona for a very long time. We're one of the few states that does provide new patient visits virtually and prescribing medication for new patients virtually. I'm not saying that that's the only answer, but what I'm saying is that there are solutions to those things, and so we're not trying to make any rash decisions here, but we thought very carefully about that, and the emergency room isn't always the only answer.
I'd like to speak on that too, because I went to our district website and went to our online provider list, and I looked them up and I printed them off and I started calling them. And I don't know who updates our provider list, but we need to look into that and get it updated, because I'm searching for primary care doctors and I'm calling and she does skin growth and hair removal. I'm like, well, that's not going to help me. And then one person, I called the phone number, it was Hospice of Havasu. I'm like, well, that's not going to help me. A lot of them aren't accepting new patients. They recommend getting your paperwork in right away because they're slammed, which is a concern when you have a large staff that's going to now need a doctor. So that is a concern I share. And then...
But I also provided you with a link
right.
to look for other providers. That
right, and I haven't had a chance to look at that because of just the timing, but I would... Aaron, do you know, is it Blue Cross Blue Shield that keeps that up to date?
It is. It is, yeah.
Can we direct them to maybe take off the people that have died? Because I called one office and they said the physician had died, and then I felt awful.
I think we can let them know.
Amy, this is Jamie. Can I ask you a quick question on that?
Yes.
Was that a printed directory that you were accessing, or did you actually go to a website?
I went to our district website and I printed off the list. So it was
okay.
supposed to be up to date.
The problem is there's no printed directories any longer. You actually have to go on the Blues website
right.
for that. So
right.
I can work with the district to get that updated.
Thank you.
And I actually brought a thumb drive of all of the print material that I brought, and I'll be happy to leave that. And I also provided a link,
right.
And it's available. I mean, it's not, you know, I don't have a secret code or anything. You know, I just went out on, and the point of it is respectfully, Patty, that you know, the decisions and the information that we're trying to provide is thoughtful and just understanding that, I mean, when you move into a new town, you have to find a provider. You have to start looking around. It's the same thing. And if you need a pediatrician or some kind of a specialist, you have to start looking somewhere. And usually nowadays it's on the internet, or you try and find somebody that you can talk to. So I guess my request would be, don't just assume that there aren't any doctors because someone said that. Do your due diligence, because there really are providers out there that are accepting new patients. Yes, sir.
I want to address the doctor situation real quick, as I work with them every day, all day. First of all, you have doctors in town who have newer practices, are taking new patients. There's some of these guys who, if you're sick, they're seeing you today. They don't want to wait. You've got Dr. Siddiqui, you've got Dr. Lomio, you've got Dr. Kuhn. Who am I missing?
Well, I love the new nurse practitioners, like 4 of them actually, that they can do patients.
That's right. And so they're going to, if you're sick, they're going to get you in. If you've got a well visit that needs to get done, then yes, you should schedule that in advance and they can get you in. These people are great practitioners. All right, they do a really nice job and they really care about people. That's number one. Number two, telemedicine is fantastic. If you've got an eye infection, you think you have pink eye, you do the telemedicine, you pay the $5 or $10, whatever it is, they call and send in a prescription to the pharmacy, you're done. It's over. A 10-minute, you have an investment of maybe 20 minutes of your time, and you go down to the pharmacy, pick it up, and it's over. So that's a huge benefit. And then on Saturdays, you've got the urgent cares. You don't have to go to the emergency room. You've got 2 urgent cares here in town, across from the hospital, and the hospital's urgent care in Food City. And when we look at supply and demand, what happens is there's demand in our town for more doctors. And as Dr. Tassi could probably tell you, the hospital is working diligently to bring more and more doctors into our town. You've got a lot of, Dr. Weiss was here. I don't know how many of you know Dr. Weiss, who was fantastic. She decided to move. But the hospital's going to bring more of those people in. And we don't know what's going to happen tomorrow. But what we do know, when we look at it, I'll just touch a minute on the health center, what we do know about this health center in Cerner, and more importantly about the consultant that consulted us for the last 15 years is we were lied to. We were cheated. Cerner would not help us. They would not give us any information. We called to ask them to change the contract. They said, no, that's it. This is the contract till the end. We know you're losing money, but we don't care. We really don't care. And the fact of the matter is, let me just say,
I'm an employee of CERN.
I know, I'll let you talk in a minute.
But that is
Well,
not, that's
let's-
false.
Okay, I'm sorry if I said, but let me finish what I'm saying, and then you can...
Madam Chairman, this is Mike Hensley.
Yep. Mike, go ahead.
Madam Chairman and trustees, just a reminder that we are in a publicly noticed meeting.
Yes.
There is a call to the public that occurred earlier, and that we cannot go down the road of having discussions back and forth between board members and those attending on items that are not specifically on the agenda. I don't want to be the one to shut down the communication because I think the questions and issues are important, but I do want to make sure that we don't go far where we then have an open meeting violation by having discussions of topics not specifically on the agenda and outside of the public call that limited discussions to 5 minutes per topic.
Okay, thank you.
The fact is, though, that the health center has lost money every year since the end, and we want that money available to our teachers in pay and benefits, but we've wasted millions of dollars since the beginning of this.
Are there any other, yes ma'am? Can you
Why
stand
can't-
up
Yes,
and state your name?
Beverly Fix, I'm in transportation, and my question is, why can't we hear from the representatives of Cerner?
We can
And
definitely
I'm here
talk,
as a member of the public today
hold on,
for my job and my
let me write
patient.
your, hold on, let me write, I'm trying to write your name down. We can talk about what we have on the agenda, and anything that's not on the agenda, we can add to discuss at a future meeting. But if it's not on the agenda, then
So this is what's on the agenda. We're talking about the deficits and the cost and closing the clinic, and we have representatives of the clinic here that are trying to show a different side, and they're not being allowed to speak, and
She
I
just
don't
said she
understand.
was not here as a representative.
Well, she's got her opinion of a different scenario. That's my
I just
question.
don't think it's fair for someone to call Cerner crooks because, first of all, you're a member of the public too, community.
can you stand up, please,
And
and state your name?
I'm Chrissy Carmack, I'm a nurse practitioner. And like I said, I'm here as a member of the community today. This is my job, these are my patients, this is my community. And I am in full support of the staff and the teachers, and I know there is a fiduciary responsibility. I understand this is a business, healthcare is a business, and we want your money to be used the best way possible. But to call us crooks, I think it's strong words for a meeting like this, because Cerner is a for-profit corporation. There are certain things we are not allowed to disclose, and when people were not members of the board at first and asking for information, that is proprietary. There are rules and laws that they were not allowed to release some of the stuff that you guys were asking, because we are a health clinic. It's patients' records, it's their data, their diseases. We have provided annual reports every year that state what our conditions is, how we treat them. And I just think calling us crooks are strong words.
I'm not calling you a crook. It's not
And,
it's
well,
your-
saying that we're,
Company-
like you said, we're
company
off.
that would not give us
But I do completely understand that this is your money, and you gotta do what you gotta do. But I think those are strong words that you said, and
sorry.
that you don't have all the background to make that call. Thank you.
Yes, ma'am, can you, oh, go ahead. Can you stand up and state your name, please?
My name is Chrissy Lokaitis. I have some specific questions about the PowerPoint. And they're kind of threefold. They may get answered in one, so I'd like to just start at my top. You mentioned up there, and again, it went fast and I can't see the paperwork, so if I'm incorrect
I'll
in
back
what I
up,
stated.
too.
No, it's fine, but you mentioned that with the clinic closing, there would be actually becoming a surplus then?
That's correct.
Based on that money, which I understand mathematically, the numbers say that, but once our billing things that we do at this clinic now going elsewhere, is that truly going to be a surplus? Because the services will be provided another way. So I wanted to know if that is based on factual values, that you believe that that is going to be a surplus to our trust, Or is that just straight $400-something thousand deficit, $600,000 thing, we now have a surplus?
Madam
That's part
Chair.
of my question.
Madam, your first name?
Christie.
Madam Chair, Christie, we actually, that's an excellent question. What we did is we assumed that there would be no savings on the movement, because we know 100% of the dollars that are currently being expensed would go over in there. But we know based on the average cost of a visit, that if the same number of visits moved across, there'd be a savings of about 70%. So we did not include that in the calculation. So we believe we understated the projected savings.
Okay. So part of that, though, if the copays go down based on what I had looked at, because I watched the PowerPoint, I looked at the PowerPoint from the prior meeting. If they go down, then isn't that more money that the trust is going to have to be paying out? Because it's not like someone's going to stop billing. They're just not going to charge us as much. They're going to charge the trust more. Was that taken into account specifically? Because that's a lot of money. When you cut my copay in half or whatever it may be.
Madam Chair, Christie, what we did is the answer is we believe that we have ballpark $190,000, $200,000, not considering the reduction in the cost per visit, okay? So what we would do is we would eliminate the deficit. The $472,000 goes away, it's gone. And we have $190,000, $200,000 ballpark, somewhere in that range. So what we would do is take that new surplus and use that to fund the decrease in the out-of-pocket expenses for members.
Okay. Gosh, I'm trying to phrase this as a question, but it's a concern I have about urgent care moving to $75 for a copay. While I understand the telemedicine concept, they can't look in your ear, they can't listen to your chest, to hear if you're wheezing. And so I do worry about that $75 as being very cost prohibitive. I'll be honest, $50 is hard for me. We had to go to urgent care on a Saturday not too long ago, and I literally didn't know how I was going to do it. $75 would be very prohibitive, and I think that's a concern I have, and I think that needs to be rethought. So I know that wasn't a question, I apologize, but I was trying to figure out, because I had it written down and then we were talking about other things. So I just feel this is awfully fast, that these things are being done so quick. I understand that we may not be able to come up with a new plan in 18 months, but in 4 months, we would be changing literally everybody, not everybody, a good portion of our people's primary care physicians and changing what they do. I just feel that's awfully fast. If in 18 months we can't come up with a plan, I feel that, okay, fine, we see the numbers getting better, we look at the two options, we say, okay, that's what we have to do. But I'm just concerned about the time. To me, this is very fast, and I think that will be very detrimental to our staff.
Kelly Wolf. I have 2 questions. Northern Arizona Public Employees Benefit Trust do have a functioning wellness center for the Flagstaff employees. Have we reached out to them and find out how they're functioning for their trust?
Madam Chair, we have looked at the NAPEP trust because it's been the subject, it's been an item in the, every 5 years the Arizona Department of Insurance examines a trust. And the NAPEP trust has been losing approximately $3 million a year since the implementation of their trust.
Okay, but my question was, did we reach out to them in Flagstaff to find out how they're functioning? My second question is, have we quoted in possibly dissolving this trust and joining ASBATE?
Madam Chair, we have not.
Okay.
That has been done previously. We're aware from old minutes.
Correct.
That the trust has considered it. It has not been considered as of now.
Okay.
And I can tell you that we have requested multiple times bids from ASBATE, and they've declined us multiple times over many years.
Based on?
They declined to bid.
I have a letter from last year where they declined to bid our trust. They refused. They would not give a reason. My best guess would be that we didn't have enough information to give them to bid our trust. That would be my guess. But it's a letter refusing, and I'd be happy to share it with anybody.
So that might be something we could do offline, but typically my understanding with a company doesn't want to bid is because they think that the exposure is too high, or they're not interested because they think it would be too high of a risk. But any other questions? Carol?
Carol Malkowski. Question, because we keep referring to the deficit, just to get a clarification and an understanding. It's my understanding that our deficit was not created by the Wellness Center. It was created because we were not funding it. We were not funding the trust. That the district made the choice at the time. Is that correct?
Madam Chair, I don't think you can separate the two. And frankly, I wasn't here, so I don't know. What I know is that when we compiled the rates this year, based on the records we were able to reassemble, okay? It was the first time the rates had actually built in the full cost of the Wellness Center. They were being treated outside and not accounted for in there. So I really can't tell you where one began and the other one ended.
I think you also need to consider and keep in mind the fact that as we attempted to untangle the cost of the program, the biggest question mark has been forever is how much does it cost to go to the clinic? What's a visit cost? And what does it cost to go to a community visit? And that's been the 2-year question. And when we finally got that answer, it was $244 a visit to the clinic, 130 whatever the dollars was for a visit. So now we had a number. And then we also saw that we saw a 5% increase per year in the management fee on the clinic. And we also saw an increasing number on the fees for the labs and the RX on that, I can't remember what they call it, the transactional fees. And those transactional fees, when you see $1,800 for a lab test that should typically not be an $1,800 lab, and those things were not being overseen, we had no oversight in that, okay? So when we started being able to see those things, those were big questions. So now we saw, where those things were, were costing more and more money. So now we had a better feel and better understanding, and so now we were able to plug those numbers in. And again, when you see where the main part of a benefit structure is to push the participants of a benefit program towards a zero copay, and again, going back and looking at all of the years of all the meeting minutes that this district never had copies of, they do now, but when you go back and you look at that and it says, quote, we want to make sure that everybody goes to that district, that clinic, so we're going to have a zero copay there, but we're going to have a $55 copay out in the community. The narrative is, we want you going there because we know how much it's going to cost, and it's $1.2 million a year, okay, then you're building your benefit structure around that. So you have to consider the cost of that as part of the deficit because we're funding it, we continue to fund it, okay? So it has to be part of that, and we didn't have a real handle on it until we started breaking it all down. We weren't able to truly break it down until we brought on a new consultant.
Right, I just wanted to make sure we were clear that we had a deficit. The reason why we went out in 2016 and we were really concerned is because we had multiple years that the district did not fund our trust. And so we were starting in 2016 in a deficit because we had years of not funding our trust. And so...
Can I make a comment to that? It really begs the question, when you're spending $1.2 million a year on a benefit, did the district not have the money to fund the insurance, or did not have the money to fund the wellness center? Did the district as a whole overpromise all of you? Or did the district simply just shirk its responsibility to keep putting money in the kitty? And I think you could look at it both ways and have both of them be correct. From my perspective, though, I'd love a wellness center. I don't have one. And, we want to do the right thing, I think, as a district. This is a district issue. This involves everybody, not just the panel up here, but this involves everybody. So the real question is what do we do as a district when you're at home and you're pocketbook is out of money perpetually, and you've got to do something to get it under control. It's what can we cut? How can we economize? How can we pull the purse strings in and go, yeah, we're going to start to grow what we have in the bank as opposed to spending more than what we have. That's what we're really talking about here. This is your bank account. When we talk about benefits, we're talking about part of what you are paid by the district. And if it's not being managed correctly, we got to kind of tighten it up a little bit to make sure that we're doing the right things by you guys as a group, as a district. So, I don't know. I don't care which way it goes, but I do, but I don't. I don't have skin in the game at this level. But I'd love to see us make a good decision, quality decision, and something that will help the district long term.
You have your hand up, ma'am?
Chris Lopez again. You said something that prompted me for questions. Since we made the changes in June with the clinic on some of the things, like blood work, not just copays, but blood work being sent to the correct place, have we seen a change in the expenses? Has that been better? Because that was apparently quite, prescriptions, that's what it was. The prescriptions as well as, blood work going, whatever the labs, that's what I was trying to get, sorry. Have we seen an improvement? I would assume there had to be an improvement because from what I understood, it was a significant amount of money.
Madam Chair, Kristen, we have 1 month of data. So the changes went in July 1st.
So we don't know if those changes have really
They
happened
will,
yet.
frankly, they will, but
They will,
realistically,
okay.
we throw out the first 3 months because what's happening is claims that were incurred in the prior 3, 4, 5 months are being paid. So you really don't see the full impact until the first full quarter after.
So there is some chance that would be better. I'm not saying it's going to
We expect it to
deficit.
be. And that deficit, and it's a good question, that deficit takes into consideration the projected impact of those changes. So even after making those changes, we're projecting a $472,000 loss for the current year.
And I know I mentioned this, and I raised my hand and spoke at the all-district meeting last year, and I asked, I think you specifically, and then I even mentioned it
It was me.
outside. I know it was you.
They always send me in for these.
No, but my point was, I asked this question, that you guys do this. You were talking about the cost per visit. But my question was, and I had said this is a concern I have with that cost per visit that you look at. Because I spoke last year here at EBT and I explained how I did 2 visits to the clinic and it would have been 7 had I gone separate places. Were multiple visit concepts taken into account when you accounted for that per visit? Because if you just count me going in once, I went twice, but it would have been 7 times because it was handled in that manner. And that's why I don't know if that was actually taken into consideration.
Yes, they were. Because with the CERT provided files that had the number of
The things that were done.
correct, broken out, and they actually aggregated them and did consider how many things were happening, how many you could count as 1 visit or 2 visits, and how many, and then they aggregated them to come back with that cost. So the answer is yes.
Their data.
I just wanted to make sure because. Like
That was
I
a big
said,
issue. That's been a big issue is how do you count a visit?
It is because in 1 visit I was able to take care of a lot and it also I personally didn't have to make 4 co-pays. And that's not only a big difference for that, it's a big difference for me. And so I think that's why people are so passionate about this, is because these things will, for example, you said go see a doctor and get in there. I'm now going to have to spend $150 plus just to get myself and my family established for a new primary care physician. I got to pay that out of pocket just to get established. And I didn't even done anything. So that's why I think many of us are so passionate is that this type of quick decision is going to have a major impact on us.
And please understand, this is not a quick decision. Please understand that.
It's happening fast.
So this has been an ongoing struggle and issue and conversation and trying to get all of this information. And until we had a new consultant and an attorney that actually understood the type of, that had a background in insurance trust law that understood what we were dealing with, we had no earthly idea what we had or what we were dealing with or what information we did or didn't need to look at or whatever. So, I mean, this has been a very, it's been a very extensive, strenuous period of time over the last, for me, several years, but for, Aaron and his organization and for Mr. Hensley for a very long period of time. This has not been a quick decision at all. But what I want to comment on and remember is that all of this information, and this is the first time that we've ever had an actuary going into these numbers and giving us good, hard, solid data when we had before been told an actuary had their hands on this all the time, and there has never been one. So I do understand where you're coming from. I do understand that you're saying that when you go to the clinic that you've got 7 visits in one, and I can certainly appreciate that, but also understand that when you were having a zero copay, that entire cost of that was being borne by the continued increased premium of that. And so it wasn't just you having a zero copay and what you saw as 7 visits in one. It was the continued increase of those premiums and this unsustainable deficit that we just can't bear it anymore. So we're trying to make good choices for this plan and going forward into something that, that we can sustain for you.
Well, I understand that because I want good choices for my plan and I want good insurance for my family. But having at the meeting, looking at, okay, there may be an issue with the trust or with the clinic, but we're stuck in a contract till 2020. Last week, we find out that it could close in December. That's fast. So it may not have been fast for you. It's fast for us.
I do appreciate that. I really do.
Madam Chair, was there any type of a non-disclosure agreement involving the negotiations on this?
I'm not sure that I understand the question.
In other words, when you found the opening to go back into discussions with Cerner, could you have told the staff at any point until the negotiations closed that closing the clinic would have been a possibility?
We posted our agenda, I believe. Mr. Hensley or Aaron, do you want to comment on that?
I think that's a...
That's a Mr. Hensley
Yeah, I think that's a
question. We
Hensley.
posted our agenda. Mr. Hensley, do you want to comment on that? Did you hear the question?
I did. I heard the part about non-disclosure agreements. That was the first part I heard. I didn't hear the rest of it.
Do you want to, John, do you want to stand up and say your question
Sure.
louder so Mr. Hensley can answer it?
Mr. Hensley, my question was the trust under a non-disclosure agreement with Cerner during the negotiations to where it could not have told the staff that closing the trust or closing the wellness center would have been a possibility?
The NDA, or the non-disclosure agreements that we were required to enter into at the request of Cerner, limited our ability to talk about information that Cerner provided to us. It did not specifically include discussions of whether or not one of the options was terminating the clinic, but it was basically the reason was to negotiate terms. Because keep in mind, as Aaron said at the beginning, we have a contract with Cerner, the trust does, that was void. So we were already in a spot where we no longer had a legal contract with the clinic. And so we rectified the situation to enter into a ratification amendment so that we could keep the clinic going while we did in fact then get information to determine the economic viability of it, the services provided versus what might be provided to a vendor. And as a result of that, we were asked to sign the NDA by Cerner because we were actually sharing kind of confidential information from Cerner about how they operate their clinics with the actuary. So both of them had to enter into non-disclosures so that everybody could be candid and be real about costs and expenses in reaching a decision here, either to enter a new agreement with them, with Cerner, or not. So I hope that answers your question.
Yes, thank you.
Madam Chair, I just want to make, I need to say this real quick. This center was brought to us, and I didn't even know until very recently that it wasn't very popular when it was brought. And they were promised, this district was promised a $1.6 million savings. Within those minutes that I'm pretty positive a majority of people sitting in this room have not read, there was talk about increasing premiums. And then there was also talk about we can't afford it. And then there was talk about eliminating staff in those minutes as a way to keep the center open in those minutes. And then the staff was told in 2016, please help us. Please help us get to the bottom of this because we don't know what's going on in this district. Please help us. And you did, and I'm very grateful for that. And the meetings became open, and everybody was able to watch them and ask questions all the way along. And here we are after we've dumped $2.7 million into it, trying to get every answer and be transparent. And it's very disappointing that there is a staff organizing against the truth. And that's the way I see it. And I'm really sorry that it feels quick to everybody, and I'm really sorry that this is maybe not a popular thing to discuss, but the facts are the facts, and the minutes are there for everybody to read. And I think, no.
Oh, because you looked at me.
I'm looking over my shoulder. I'm sorry. Here, let me stare at the wall over here. I want everybody to read the minutes where they want to eliminate your jobs in order to keep the center open, and then come back and tell us how upset you are that the due diligence has been done, that this doesn't make financial sense, it's killing this district. We can provide you better benefits, lower co-pays, easier access, even though there's rumors that won't be true. But I encourage everybody to at least do your own due diligence, because Mrs. Cox has gone to great lengths to make sure that everybody has access to that information. That's all.
Yes, ma'am. Can you stand up and say your name, please?
Yeah, Mary Jo Mulligan. I would, and I don't know how to say this in a question, but to just ask that consider, in the midst of all of this, when all of these things were happening over the last 5 years, most of us have created really deep relationships with Chrissy and Diana at the clinic. And so that has nothing to do, and I'm not taking away from any of the numbers or anything, but you know, it's those relationships. And for the first time, sometimes I will speak for myself, that I had somebody who really knew all that. And that's just an emotional thing. It doesn't mean we don't think any of this is important or any of that, but in the midst of the messiness, those things were happening.
Of course.
And so that's 5 years coming, you know, for us, and then to consider that's, and again, I'm not saying it's not wise or any of that. I believe in this group, but it's important.
Of course.
You know, it just is, because it's been a long time coming to create this relationship.
Of course. State your name, please.
Catherine Hubert. I do have a lot of skin in the game. My little family of 4, the clinic, there are primary care physicians, we go there for everything. But here's my question, because I am completely open-minded on this. I also know after the recent dependent coverage increase, that was huge, and I did discuss it with Marcia. That was a huge increase to my family with the income that I make. By closing the clinic, is that going to help us when we have new premiums come in? Or are dependent premiums going to just keep rising anyways, and now I'm paying all this money for co-pays that I wasn't paying, but my premiums are still going up? Do you understand what I'm asking?
I do.
I mean, I know you can't see the future, I understand that, but will this help those of us who have dependent coverage to get that back under control where we actually get a paycheck?
Let me answer that. And I'll answer it as painfully candidly as I can. Okay?
Can you speak up,
If it
Aaron?
wasn't, I'm sorry. If it wasn't for that, if it wasn't for the deficit, if it wasn't for the fact we adopted a budget with a deficit, the premiums would have to be higher today. Overall, we'd have to collect another $472,000. So frankly, they're artificially suppressed today. And I can tell you, having gone through the numbers since last October, so for 11 months, that it does trigger back to that 2016 event that you guys talked, because it was cratering at that time. So however they work the magic, you got to pay the bills.
And
right?
can I just interject, and I know you need to finish this, but I just want to interject. When we looked at the premiums, the rate increase that we just went through, the recommendation, and it was an actuarially sound recommendation this time. The recommendation for the rate increase was 24.9%, and what we received was 10. So that's what we had to deal with. So go ahead.
So the long story short is the rates are artificially suppressed today, and they're suppressed by short funding. Okay, again, keep in mind the district pumped, since that cataclysm in 2016, they put $2.7 million more into it just to keep it afloat, right? So that's where we're starting from. By doing, if you look at this math, if the decision's made, right, we know that we get from 472,000 to 190 to the good, 200 to the good, ballpark. So for however that money is redistributed, right, it's either going to go into premium and leaving the benefits as they are and just reducing premium, right? Then the district decides how to split that. Or you can actually use it, which is what we were proposing and what we're studying now, is can you use it to offset copays? Can you offset, or some copays, deductions, co-insurance out of pocket? How do you treat those dollars with the idea being sustainability? Parallel universe, the district has a policy. They put those in, and I don't know this, Mike would have to jump. I don't understand that part. My job is the healthcare part, okay? But when that whole thing happened, the district increased the subsidy to lower the cost for dependent care, to kind of avert the crisis, right? That's in addition to the $2.7 million. They're trying to unwind that. Okay, so what that means is the costs are shifting. So I know it's complex, I know there's a bunch of moving pieces, but when I look at that 190,000, the needle that we're going to have to thread is how do you use that to have the greatest good? Because healthcare right now is inflating at about 8% a year. So how do you do it so that you can get it back to some semblance of balance where it's affordable, both on the out-of-pocket cost and on the premium cost, and then how long can you sustain it? So it's a moving target. I have no problem saying I'm pretty comfortable with the numbers now that we can actually find a reasonable ground at this point with those dollars. How long it's sustainable in that healthcare environment is anybody's guess. We tend to be a conservative firm, right? So we tend to look at things, and conservative means we tend to look out 3 years. So you'll have people project 5, they'll project 7. We will rarely go beyond 3. And even then it's high with lots, like I did before, lots of asterisks, hey guys, we don't know. And the reason for that, for you guys, for everybody to know, this is a small group. There's only 400 employees in this group. You throw in just a couple of cancers, nothing dramatic, no gorillas climbing Empire State Building. You just get a couple of cancers, you get a kid that steps in front of a car, gets run over goes through the prop out on a lake on a summer weekend. 2 or 3 of those cases will flip this thing, okay? Because right now its financial solvency is attributable at $2.7 million. So that's the struggle. So it's not, you don't know who's going to get breast cancer. You don't know whose kid's going to get run over by a boat. You don't know who's, just fill in the blanks. So you build your numbers conservatively so that you can withstand those ups and downs, and that's the struggle. And that, frankly, that's why the whole nation has this debate, guys. It's how do you do it? Because at the end of the day, to me, it's a dollar. But we realize that behind every one of those dollars is a face, okay? And that's the struggle. How do you keep it affordable? How do you keep it accessible? How do you keep it, the out-of-pockets, all of that? And it's tough. It's a Rubik's Cube. But frankly, we've been doing it for 27 years.
And if that 2.7 million didn't come from, expected dollars for premiums, it had to come from somewhere.
Somewhere.
It had to come from, I don't know, tell me, Mr. Murray, or Vice President, it came from, what, some proposition?
It came from
Prop 123.
Prop 123 money, the settlement that we should have received $1 million of. It went, instead of going into staff salaries or whatever else, it went right into the trust.
So if it hadn't gone to help shore up the trust, it would have gone,
Into the M&O budget to be spent elsewhere.
So, Aaron, you said sustainability. If we do nothing today, how long is the trust sustainable for?
I've been asked this question a million times, and it's a guess. I would say 18 months. And the reason I say that, just so everybody knows where that number comes from, we're looking at the patterns, and actually right now it's doing okay. But with the built-in structural deficit of 472,000, given the size of it, right, instead of being able to withstand 4 hits, it's only, maybe it might be 2 that flip it. So our guess, just based on the normal, the way it works out, you see several of those a year, you just need a confluence of maybe 2 or 3 extra in a year, and it goes in solid. That's a guess, because I don't know who's going to get cancer, I don't know who's going to get run over by a boat. But that's based on my experience watching stuff.
Because I'm short. So is our reinsurance not valid?
The reinsurance is there. That's
yeah.
that's even taking the reinsurance into consideration. I mean, that's all of that. That's assuming that's there.
But reinsurance caps at a certain point,
Of
correct?
course.
Yeah.
And everything below that is.
We don't even worry about those. Honestly, that's their problem.
Right now,
Yeah.
that's why I was like, there's only so much.
Yes, ma'am. Can you state your name, please?
Sure. My name is Stephanie Chase, and every day I have 200 students walk into my classroom that rely on me to be physically fit and well, and I rely on the Wellness Center staff. They have always been there to support everything that we've done. The level of care that I get there exceeds anywhere I've ever worked or lived, by hands down. And the peace of mind that they give me when I'm in my classroom with my students, knowing that they're there for me, is second to none. My curiosity or my question when it comes to the teledoctor, because I understand that the board has a financial responsibility, I understand that, but from the teaching perspective, how is a teledoctor, how am I supposed to build that rapport and that peace of mind with a teledoctor that is then going to give me peace of mind to be there for my students who rely on me, like the Wellness Center does?
I can answer that. First, the teledoc's not meant to take the place of a primary care physician.
Not at all.
Okay, so it's there as a supplement, 24/7, 365, anywhere you have a phone access. You can visualize, you can do it by phone, you can schedule it, or you can call and have them call you back. So what you get is expanded coverage. And what we say is it's for the Cillin events, the ampicillins, amoxicillins, penicillins, that type of thing. So the pink eye, the UTIs, the stuff that you know in your judgment does not require that you go in immediately. There is no replacement for an established primary care physician relationship for your family. So what happens here is you switch, and you may struggle. We know that. Okay, you may struggle to establish one, but I think what the chair said and what we've all said, you guys are in Havasu, you've got this massive snowbird community. Don't wait till December. So you're going to have to go in and get it done, and you may still struggle. I'm not telling you it's a perfect world, but the combination of the two, you'll never duplicate the clinic because the model's different, right? But I believe that we can do the greatest good to the greatest number of employees by expanding access to health care, by lowering copays to get the out-of-pocket expenses down, and by offering an alternative, not a replacement, but an alternative that actually has expanded coverage. But I would agree with you as a father of 2 kids, right, and a family that all work in healthcare, that there's nothing that replaces a good primary care relationship.
No, I don't believe anything can replace the staff at the Wellness Center.
Do you have any other questions?
Can I just address what Nicole is concerned, like there's an uprising or whatever?
You can address the board.
Can I just?
You can address the board.
Marsha, what I will explain is that we're all here because we received an email from our superintendent that had your name attached saying that you were concerned that we didn't show up in the last meeting. So we're here. And I just want you to know that that's one reason why you see a great number here. I already reached out to you why I wasn't able to make last meeting, but the numbers that are here are because the words that came from you to district staff.
I appreciate that. Do you have any other questions or comments from the audience? Any questions or comments from the board?
I know I've already mentioned updating the online directory, but it would be nice if something were to happen where the clinic did close, if maybe our personnel people could work to make the transition as easy as possible and go through the list, make sure that they're actually active members and provide it for all staff at that open enrollment meeting or before, because apparently we should be calling soon if that were to happen.
Can I just make a comment on that? Jamie mentioned that she'd work with district staff to get that link onto the website. I have a note here and I'll follow up with her tomorrow.
And I think from what I've noticed just by using it, the way the link to me might work is if they're capable of being primary care, they're labeled primary care. Because I know Tammy worked at the staff, she was a primary care nurse practitioner for a while, but now she's doing dermatology and she's listed as a primary care nurse practitioner.
Yeah.
So I'd like to see all of those names eliminated before we provide it to the staff so that it doesn't add that level of frustration.
Wouldn't it be really simple just to put a link to the Blue Cross network?
That's what we have, and that's the link that's outdated and not working.
To provide a little feedback, a lot of times the directories will list us as our degree. So for instance, Tammy is a family nurse practitioner.
Right.
So they are going to list her as family, but as you stated, it's correct because she's not practicing as that. When you call, you're going to find out she's doing something different.
Right.
But we are going to be listed by our specialty, so that might be why you're seeing a little bit of inconsistency there. But like you said, there are some on the list that may not be practicing, and so I agree the list probably needs to be combed through. But that might be why you're seeing some of that inconsistency.
Anything else? Aaron, do you have anything, any other comments?
Don't, Madam Chair. I want to check with Jamie too.
Jamie, do you have anything else, or Hal?
No.
Nothing from our end. Mike? So just a reminder, you've got two issues to decide. One is to, you've informed the trustees of and the members of what's going on so that the agreement that we have will run its course, or if any trust member wishes to make a motion to enter a new agreement under the proposed final terms with Cerner, that would be the other action item that could take place today.
So,
If there is no such motion, then that would die of its own accord.
if there's no motion, then then we're not accepting the offer from Cerner, and then it's sunsetted and we start winding down.
That's correct.
So my recommendation is that we're not going to make a motion and that we're going to wind this down for all of the reasons that have been discussed for the last 2 hours. But I don't know how to finish that out as far as there being a recommendation now.
Madam Chairman, as counsel, what I would do is just ask if there's any member who wishes to make a motion to enter the new agreement with Cerner, and if not, then there's nothing further to do because the existing agreement will wind down of its own accord.
Okay. Is there any member that would like to entertain a motion to enter into this agreement with Cerner? I don't hear any entertainment of any motion, so I think our business is done. And we will move forward with letting this wind down. And we will move forward with making arrangements to contact Cerner and start getting the information that we need to the employees and everything that we need to do to make sure that this is a smooth transition. Anything else? So we have a motion to adjourn? We have a motion, do we have a second? A second? All those in favor? Aye.
Right.
We have unanimous ayes.
Tell Jamie.
Jamie?
Madam Chair, can you just tell me who made that motion?
Dr. Tossi and
Thank you.
Amy will second it. And we had unanimous ayes, and we adjourned at 5:59.
Got it. Thank you very much.
Thank you.